this Oncofertility group webinar. My name is Richard Anderson. I'm at the University of Edinburgh in Scotland, and I'm moderating tonight's session. And I'm delighted to introduce two old friends and serious experts and contributors to this field, who I'm sure will give us a lively presentation and plenty of thoughts for discussion and debate. So I'm very much looking forward to us. The format tonight is we're going to have two talks and then plenty of time for discussion afterwards. So keep your questions for the end, and please don't hesitate. There's no such thing as a bad question. Join in, chat, see if you can get a good conversation out of our two speakers tonight. So our first speaker is Irene Su, San Diego. She's Professor of Reproductive Endocrinology and Director of the Infertility Fellowship there in the Division of Reproductive Endocrinology and Infertility in the Department of Obstetrics, Gynecology and Reproductive Sciences at UCSD in sunny San Diego. So Irene, we very much look forward to your contribution tonight on post-treatment fertility preservation for patients with diminished ovarian reserve. So over to you, Irene. Thank you.
Yeah, thanks everyone. I like sort of this format. I know we've been on Zoom for a long time, but I appreciate the opportunity, and it feels nice to talk about this really, hopefully at the end as a discussion among, friends and people who have been in this field with us for such a long time. So let's get started. So this is meant to be case-based. This is a 14-year-old G0 who is 6 months after a hematopoietic stem cell transplant for bone marrow failure, and she really presents with her family to discuss future fertility. The exposure that we received from her oncology team is that she underwent RIC, which is reduced intensity conditioning prep, with Campith, fludarabine, melphalan. And then the total dose of melphalan is 140 milligrams per meter squared. And that translates into a cyclophosphamide equivalent dose of 5,600 milligrams per meter squared. This was a matched unrelated donor transplant, and she's now doing well. So the question that I'm trying to bring up and trying to sort of answer is, when is fertility preservation post-treatment optimal, and how? And I think much of the how Pasquale, Dr. Patrizio will also, go through after my talk. So this is a graph that I typically show, indicating that in blue, this is the normal age-related decline we have in oocyte numbers over reproductive life. And that if you are young and you undergo cancer treatment, and we group things as the exposure as being low, moderate, or high toxicity, then conceptually, for high toxicities, for example, if you remove both ovaries because you have ovarian cancer, that is a higher stage, then your fertility is done, right? And then if you undergo methotrexate for gestational trophoblastic disease, then hopefully the trajectory is green and you really remain parallel to that you otherwise would have had you never had chemotherapy. But really the vast majority of folks who are treated with cancer treatments are somewhere here in the yellow, in the moderate toxicity, and then so that you lose some, and that changes potentially when you age out, and it changes potentially what your window of fertility might be. So this is to really summarize to say that differential treatments confer differential risks. And your differential risk then limits or helps to guide and tailor what your post-treatment fertility preservation decisions would be. So we've done some work estimating the window of ovarian function after cancer treatment. And largely this literature uses the hormone AMH because AMH is a measure of the functional ovarian reserve. So the idea of AMH coming from primary, secondary, and late secondary follicles, and that if these follicles are proportional to the underlying pool, then potentially you have some measure of the underlying pool. And you know that the normal trajectory or patterning of AMH over reproductive life is low for females at birth, really reaching a peak somewhere around age 12, 13, 14, plateauing for about 10 years until age 25. And then for those of us who are reproductive endocrinologists treating patients, that decline that we see, once you're mid to late reproductive age. That pattern is very different for cancer patients. And so when I was a fellow, Dr. Anderson had this paper, and I think that paper really drove the start of my academic life. And he had shown in a cohort of breast cancer patients that prior to treatment, and treatment here is indicated in black with chemotherapy, that AMH levels are normal, because I think that the average age of this cohort was probably somewhere in their mid to upper 30s, but that with acute treatment, you have a drop in AMH. And this is really because chemotherapy is killing off that growing pool of follicles. And then this is the very first cohort that I know of its kind, ended at 12 months, because it takes so long to get to young cancer patients and follow them serially. But there was some, to me, hint of like, well, what happens after 12 months? It looks like there's an uptick. And so that informed a study that then we did over 5 or so years. So this is a study in which we recruited people who were diagnosed with cancer between 15 to 39. So this is an adolescent and young adult female cancer survivor population. These individuals were post-treatment. We asked them to get dry blood spot AMH levels at home, and then sent them the dry blood spots in for us to measure AMH. And because someone could have been treated on the left end, so immediately we recruited them immediately after they finished cancer treatment to an AYA cancer survivor who's 15, 20 years out of treatment, that if each person contributes about 18 months worth of data on AMH levels, we can piecewise put these individual AMH trajectories together and put it as a whole to get an idea of projecting out what the pattern of AMH might look like after cancer treatment. And so this is the overall picture. We're using principal components analysis, and this is the work of Brian Kwan, who's now a PhD, but he was our PhD student. You're seeing the log of AMH by year since cancer diagnosis. And so where you saw previously Dr. Anderson's work that showed acutely AMH levels fall, we are really asking, after AMH falls with cancer treatment, is there some recovery thereafter? And so what you're seeing here is that for the overall population of AYA cancer survivors, we see recovery over the first 2-3 years. Then we see a lot of plateau time, and then really the decline starting at 18 to 20 years or so. The lighter pink lines behind here are individual trajectories. So this should give you the first hint that not all cancer treatments are the same. And so how do you then figure out, do these trajectories differ by how toxic the treatment exposures are? So the take home of this is that after cancer treatment, AMH reflects ovarian recovery, and you see a prolonged plateau and a fall, and that these AMH levels will fluctuate over time. So single measurements probably do not indicate the level or the potential for recovery. So this was published by the Oncofertility Pin Group a couple of years ago now. And this is to say after that the Pin Group had reviewed the data on different cancer treatment exposures and fertility or reproductive outcomes, that the main exposures that were deemed to have fertility risk are alkylators, and then the level for indicating risk depends on whether the exposure was prepubertal or postpubertal. But suffice it to say that as the PIN grouped into minimally increased risk, significantly increased versus high, kind of low, medium, and high, that the highest level of risk would be over 8 grams per meter square of CED, because we had postpubertal patients, and then somewhere in between 4 to 8 grams. For radiation, anything over 10 to 15 gray would be considered high risk. So this is published after our analysis, so let me show you what we did so that you have an idea for comparison. So we called low toxicity anybody who had endocrine therapy, radioiodine, surgery alone, because we did not think that that was directly toxic. We called anybody high toxicity if they had radiation of the pelvis, transplant, or a CED of over 7 grams. And then everybody else in between is here in the moderate toxicity group. So if you stratify by this definition of low, moderate, and high, this is what we see. So the green is going to be your low toxicity group. That post-treatment, they had this recovery, but that compared to the moderate and the high toxicity, the recovery is the highest. The plateau time looks similar to the moderate, but it's in this severe group that you have the same amount of timing to recovery, but the amount at plateau is short. we had relatively few people in the high toxicity group. So I think that this elevation is actually false. It's probably being driven by a few people up here. So I think that from here, we felt that the magnitude of recovery really varies by toxicity. And then the length of time that you spend at plateau varies by toxicity. So the reason why this is potentially important to the discussion of the case today is that if you know the amount of time at plateau, that might impact how you counsel a patient about fertility preservation and the timing of that post her stem cell transplant. And lastly, this is just the last data slide to say that the relationship between age and AMH, it depends on how toxic the treatments are. So here we divvied into low toxicity, moderate, and high toxicity in these 3 different graphs, and then by the age at treatment. So the pink is going to be the youngest, the blue is the middle, and then the yellow are individuals who are over 30 at the time that they were treated. So if you're in the low toxicity group, your AMH trajectory in the 2 younger groups look the same. Same thing here in the moderate toxicity. But if you have high toxicity, even those who are in their 20s at the time of diagnosis now much look like those who are over 30. So that's really the contribution of your underlying ovarian reserve to that toxicity, to the exposure that you're getting from cancer. So ultimately, that trajectory is a combination of what you came into a new diagnosis of cancer with, what your ovarian reserve was, in addition to what you were treated with. So of late, it's been pretty fun to look for other data sets rather than recruiting 1 patient at a time. And this is just a demonstration slide done by just published, but done by the work by one of our REI fellows, Beth Jo. We took claims data, so large, big data using healthcare claims that also have AMH levels or biomarker levels can then be leveraged because you can better capture what treatments are. And so here I'm just showing you the AMH levels for cyclophosphamide-based breast cancer treatment, which is here in pink. This is at the time of diagnosis, so this really captures kind of the work I showed you from Dr. Anderson. Initially with treatment, AMH levels fall. And then our work that you can see after treatment, you can see this recovery in the pink. What's in the black and what's in the gray are people with no cancer or people who had breast cancer surgery but no chemotherapy. And what was curious about the smaller data set of platinum-based chemotherapy is that they looked much more like chemotherapy for cyclophosphamide than they did like the no chemotherapy group, suggesting that platinums may also be a risk factor. So the data on post-transplant are less good. This is what we know to date, which is that if in this study, the exposure was allogeneic transplant, and so they called this alkylators plus minus TBI. The dose of TBI is in the high toxicity group as defined by PIN. The outcome was infertility, measured by either amenorrhea, menopausal hormone therapy, or high FSH in conjunction with low estradiol levels. At a median follow-up of 6 years, 72% of those who were age 1 to 12 at transplant met the definition of this outcome. And there's an age interaction because it was 91% in those who are 13 or older. But this is traditional allogeneic transplant, and I guess the question is it different with RIC or reduced intensity conditioning? So let me show you some of those data. Oh, sorry, the last point that I meant to make here is that even at 6 years out, many patients who underwent traditional allogeneic transplant continued not to meet the definition of infertility, and that this cohort still suggests that there may be a window of ovarian function in a smaller proportion of transplant patients. So 2 different studies. On the left, this is a really small series of individuals who underwent reduced intensity conditioning for transplant and looking at what their FSH levels are. And you start to see, yes, there's a few that go up really high, but in this small series, also some that remain low. I think that this poster that was recently presented by a consortium of pediatric centers that do transplants for hematologic diseases, I think this is better. So what they're showing is in a small cohort, and I think this cohort had, let me just try to find it again, 34 individuals, females, who underwent transplant. On the left is RIC exposure. On the right is allogeneic, the traditional allogeneic exposures. And so everybody had AMH levels drawn at the 2-year mark post-transplant. And so on the left, you'll see that for RIC, the proportion of detectable AMH is higher than for traditional allogeneic transplant exposures. So specifically, 63% of those who underwent RIC still had detectable AMH at 2 years, as opposed to 9% of those who had the traditional exposures. Okay. So in conclusion, and how that informs our clinical decision making, is that for many cancer treatment exposures, there's some extended duration of time during which AMH is stable. And if you think about AMH as a predictor of the number of eggs that you could get, then that time when you hit the plateau for someone who ultimately will have a shortened window, that would be actually when you would counsel on fertility preservation. That time depends on how gonadotoxic the treatment was and how old you were at the time of treatment. And so this again sort of goes to the point of this informs when fertility preservation is optimal. For high gonadotoxicity exposures, including hematopoietic stem cell transplants, that potential window of ovarian function is possible. I think our data would suggest that that peak is somewhere at 2 to 3 years post-treatment, but nobody has large numbers. And so practically what do is we do serial measurements of ovarian reserve. And when they plateau, and I think that doesn't seem to change a whole bunch in about 6 months. So clinically, we serially measure every 6 months or so to optimize the timing of ovarian stimulation. And I think a part of this counseling really is decreased ovarian reserve is only a predictor for whether we're going to get 1 egg or a lot more eggs, but is not a predictor of fertility. And so this does not preclude unassisted attempts to become pregnant even when someone has very diminished ovarian reserve. So I'm going to stop there and then turn it over to Dr. Pasquale.
Irene, thanks very much indeed. Fantastic amount of data there, beautifully presented, and some clear clinical messages at the end, which is really great. So I'm sure lots of people will have questions and comments for you to bring to the discussion afterwards. But first we have Professor Pasquale Patrizio. He is currently Professor of Obstetrics, Gynecology and Reproductive Sciences and Chief Division of Reproductive Endocrinology at the University of Miami Miller School of Medicine. But I think it's just worth remembering that his career was established on the basis of some early training in Scotland, Pasquale, and we mustn't forget the early Scottish contribution towards your stellar career. But tonight you're going to talk about primary ovarian insufficiency and some novel approaches to fertility preservation. So we look forward to your presentation tonight. Thank you. You're muted. You need to press the button, Pasquale. You're muted still. I'm sorry, we still can't hear you.
Yes, can you hear me now?
Now's good. Perfect.
Yes,
great.
Thank you so much for the introduction, Richard, and thank you, Dr. Su, for a very nice introductory presentation, very exciting. So let me quickly go through my presentation. Basically, what I'm going to be covering is what happened when a woman has not been able to either preserve fertility prior to treatment, or after all, there is a condition that we call premature ovarian insufficiency. But basically, the reason why I do this part of the talk is to see, okay, what are the experimental options available today? What's really in the pipeline to try to help patients that are now with the diagnosis of premature ovarian insufficiency? So I will talk about 3 options: the PRP or platelet-rich plasma infusions, the in vivo activation that seems to be a little bit on the sideway, but is worthy to know historically what was the great promise on that treatment. And finally, the exciting work of Dr. Sherman Silber and Hayashi from Japan on where are they in manufacturing gametes, eggs in the instances, from skin cells, fibroblasts. So basically,
sorry, Pascali, can I interrupt you a second? We're seeing two slides for you, which is a bit confusing. Are you able to change to switch to the main screen?
Okay, let me see if I can do that. Sorry about that.
Up top, there's a display setting. Do you see if you switch that?
Yeah. Yep.
Yeah, that looks great. Thank you.
Thank you so much. Sorry about that. So in terms of initial definition of primary ovarian insufficiency, diagnostically speaking, FSH that is more than 25 or 32 times with the measurement 1 month apart, a minimum of 4 months of amenorrhea. And the incidence by age 20 is about 1 in 1,000. By age 35, 1 in 250, by age 40, 1 in 100. Now, this also impacts 10 to 50% of women that are status post chemotherapy. And most importantly, patients that they undergo stem cell transplantation, because even though some may still recover, as you will see in a moment, the chance of conception is probably no more than 1%. Now, again, it's preferred the terminology of insufficiency and not failure or menopause, because some of these women may still have some ovarian function. What the reason I put these slides on and I bolded the concept of cancer genetic mutations is because it is still important. If we are facing a patient with a premature ovarian insufficiency after treatment, that we do some of the workup, because we want to rule out other possible reasons for the POI. In addition to the chemotherapy or the radiotherapy, there has to be something else that has to be ruled out. And in particular, it is interesting to make sure that we know whether or not the particular cancer that the patient has been diagnosed with were cancer that had a genetic component. Because we know now that the BRCA1 gene mutations, for example, they are associated with the diminished ovarian reserve. There are P10 mutations that also are associated with an earlier exhaustion of ovarian function, because of the impaired DNA damage response, which may wipe out the primordial follicle and induce ovarian aging. So again, the importance of knowing what was the possible etiology, if there was one, of the original cancer. And there's also a work that our moderator, Dr. Anderson, did very recently about this P10. And then also ATM. So in bold are all those genes that have been recognized as being potentially associated with the decreased ovarian longevity. That's why I put it here. It's important to know whether or not the lack of recovery or the short lifespan after treatment may also be compounded by the presence of cancer mutations. Now, what about the options that I'm going to talk to you about, which again are all experimental? One is the PRP. These are slides that I have from my colleagues, investigator in New York, Dr. Gleicher, Dr. Barad, and Dr. Albertini. Basically, what they've been doing, they've been extracting PRP from patients. And why PRP? To be injected into the ovaries, because PRP contains a lot of growth factors and cytokine that may play a role. So what type of role are we talking about? Well, the role where these two arrows are, that perhaps these growth factors that are into the rich platelet component, they may be able to help recruiting the primordial follicles and growth of oocytes because of this cytokine and this growth factor. So again, there is not yet a full detailed understanding on where this PRP extract may be playing a role, but the current studies are so organized. The clinical trials that the center in New York is doing are really using two types of PRP protocol. One, the one that is interesting to us, is the so-called PRP type 1 studies. They are still recruiting, so started in March 2020, is still ongoing. And they so far had 20 women with premature ovarian insufficiency. They are 40 years old or younger with the documented POI, normal karyotype, the MH values are listed here. And then they have a PRP2, which is more for women that are older. They have either an occult POI or they have a severe decreased ovarian reserve, not necessarily patients that are as a result of a chemotherapy or radiotherapy, but those are patients of a poor ovarian response. That's very schematically how to prepare a PRP. You have a collection of about 8 ml of blood, then you put into a centrifugation. And then once you centrifuge, just here at this interface of the gel separator right here is where the rich platelet component of the plasma is collected. And then just to give you an example, this is a poor sample because there are very few platelets here. And here is a good sample where the rich component, about 100 million platelet per ml. Now, the study involves that patients are under anesthesia, the same anesthesia that you do when you do an egg retrieval, and then 7 to 10 sites of the ovary that has been chosen for blinding for the experiments are injected with the PRP. And the other ovary serves as a control in the PRP1, or in the PRP2, again, the patients that are with the decreased ovarian reserve, not necessarily, those are not patients with the chemo or radiotherapy, they have both ovaries injected, okay? And then they follow these patients every 3 days for the first 15 days, and then weekly for up to 2 months after the injection of PRP. So these are the baseline characteristics of the patient enrolled so far. These are the group that we are more interested. You can see that these are the mean age, 34.5, and the FSH value, the mean 85, and the MH 0.02 as a mean. And look at the months of amenorrhea. We are talking almost as an average of 10 years of amenorrhea. And so far, again, I'm thankful for them to share these very preliminary results. We see that 2 patients out of the 20 in this group.
The plasma, this is absurd.
Can someone please mute the microphone, please? So you can see that out of these 20 initial patients that were treated with the PRP, 10%, underwent retrieval of an oocyte. Each of them had 1 egg. And one of these patients had been menopausal for 15 years post-chemotherapy, and was able to produce an oocyte, had no menses for 9 years.
Tissue transplantation is going to come to this region, or if anyone's even doing it.
What, ovarian?
Sorry, could we have some microphones on mute, please, other than the speaker? Dr. Cicerni, your microphone's not on mute. We can hear what you're saying.
Yes,
could you mute, please?
Thank you.
Because the people here are too wrapped up in IVF and donor eggs. We can't do it, of course.
You know, I have the worst case.
Can you please mute the
Sorry,
phone?
guys, can we keep the
Alan?
discussion to the ends, please? We don't want to hear private discussions at the moment.
I can take care
Dr.
of that.
Patricio is trying to give his
That's
talk.
not pregnancy.
That sounds miserable.
Huh?
So I will continue, but hopefully Dr. DeCerny will realize that he has a microphone on. But in addition to the PRP, the work of Dr. Pellicer is also including injection of autologous stem cell ovarian treatment. That's called ASCOT. So it's autologous stem cell ovarian transplant, and has been showing some result, but again, extremely experimental, and we are waiting for more data. The second option that is available as on an experimental basis is called in vitro activation. And this was originally proposed by Dr. Kawamura from Japan in the group of Dr. Nao Suzuki. And basically the concept relies on that primordial follicle, they are kept quiescent by the action of the P10, and then they are also kept quiescent and dormant with the action of the PI3K. So therefore, if you block an inhibitor, the P10, and you activate the PI3K, you can theoretically, by disrupting this, this mechanism of control, activates more oocyte primordial follicle to go towards development. And that's the basic concept. He tried it in mice, and essentially you take ovarian tissue, you place it in contact with the P10 inhibitor and the PI3K activator, and then you transplant under the, into the kidney capsule, you treat with FSH, and that should lead to a collection of oocytes. These are the animals once they were analyzed histologically, and just to show that on the top, control ovarian tissue here, on the bottom, just P10 inhibitor, here control ovarian tissue, and only PI3K activators. But when they were both combined, the P10 and the PI3K activator, you can see that the size of the ovarian tissue was a little bit more pronounced, meaning that there was more of a recruitment in these instances. So the same concept that was tried in mice has then been proposed for treating women that were in POI. They had an IRB approved protocol. They were doing a biopsy of ovary, taking cortical strips. And then some of these cortical strips were minced and activated in vitro with the P10 inhibitor plus the PI3K, as we showed before in the mice. And the study was approved by the Mariana University and Japanese Society of OBGYN. They initially recruited 83 patients in the mean time of lack of menses or amenorrhea for about 6 years. So they did the study. After the activation, they did the outer transplantation of the tissue here on the serosa portion of the fallopian tube here, and they then covered the graft side with the cellulose to avoid the loss of these particular cubes that were transplanted here. So these are the original results. Again, very encouraging in that among 83 patients, they found that follicular growth was registered in 28 patients, 61%. And those were only patients, that's important, that's why it's in red, that they only had, that they showed residual follicles on the histology of the ovarian cortex. If there were no follicles seen on the ovarian cortex, there's no possibility, even if you do the P10 and the PI3K, to register or to notice any follicle growth. The important thing is that of these patients that there were 3 out of 8 that they became pregnant after an embryo transfer, 1 miscarried, but then there were 2 successful deliveries. Very promising results, but from 2015 to now, I don't know what happened to this technique, because Kawamura kind of has not produced any more information on this, and that's why it was very promising, but I cannot give you any more update on that. And the last experimental option I'm going to talk about before we open to discussion is making eggs from skin cells. Again, the work of Katsuhiko Hayashi and Sherman Silber, where basically they are taking a fibroblast and they are changing them into pluripotent stem cells. And then once they are now de-differentiated in pluripotent stem cell, they are going to be driven to become primordial germ cell, and therefore from there, becoming primordial oocytes. Let me recapitulate for you. First, what happened in vivo. In vivo, from a blastocyst, this is the inner cell mass, one keep growing into the epiblast. In yellow, if you can appreciate here, these are the early epiblast cells that they separate from the rest of the developing embryos. And here is from where all the primordial germ cells originate. So now to recapitulate and reproduce what happened in vivo, in vitro, so happen like this. You take the skin cells, you differentiate them, and then they become epiblasts look like cells. These epiblasts look like cells with a series of ingredients that are listed here. You are then going to produce these primordial germ cells. This is really the way to do it. These primordial germ cells are then going to be created in a niche of granulosa cells. They reaggregate, and then you can kind of reconstitute in vitro what can be considered an artificial ovary. The recipe that Dr. Silber put together is right here, how to make an egg in vitro. So you take skin cell, you create IP, induced pluripotent stem cells, takes about a month to do that. Then those cells need to become epiblast cells, 2 days. Then from epiblast cells, primordial germ cells, those are another 6 days. So if you do the calculation here, we are already 5 weeks to go from a fibroblast to a primordial germ cell-like cells. Then embedded in granulosa cells, for another 3 weeks, you do the in vitro differentiation, and then you expose them to FSH. You dissociate them because it's important to allow them growth. And then 1 more day, and then you can theoretically have an oocyte. Let's show here. This is now the cluster of cells that came from a fibroblast. These are mice. And then you isolate, you see this little arrow here, you isolate the secondary follicles. They need to be isolated, otherwise they don't continue their growth. And then after those 11 days, you can start to see, again, this is mice work, that they start to grow, differentiate into antral follicle. And then from the antral follicle, you add the final step is the SCG. And then from the SCG now you have eggs that are mature. And here they are. And here are the very first derived mouse pups from fibroblasts of mice. And now Dr. Silber, together with Amant Clark in California, they've been able already to generate 3 human-induced pluripotent stem cell sublines for reproductive science purposes now. So it's just research at this point, highly experimental, but think about here, taking cells from a 55-year-old woman that was previously fertile, they've been able to induce pluripotent stem cell, primordial germ cell look-like from the skin cell of the 55-year-old, and now they are trying to produce or start the process of in vitro differentiation as is happening in mice. So this is very exciting research. I'm very much looking forward that perhaps this can be a great solution maybe in a few more years. In conclusion, we still have some work to do. That, like Dr. Su was mentioning before, maybe the AMH is it really a valid endocrine measurement for the ovarian return of function? Is there any more importance of the AMH together with the chemotherapy, with the age? Maybe should we consider the breast cancer gene as a background? So all of this is all up to continue to study and create perhaps a roadmap that we can follow when we see patients that they have either not recovered their ovarian function or they went into premature ovarian insufficiency, and to have something to counsel and talk to them. And that's all what I have to say. I'm looking forward to have a very good discussion. Thank you so much for your attention.
Thank you very much, Pascali. Very thought-provoking talk. Great. So we've got a little over quarter of an hour for some discussion. We've got a number of people in the audience. We've got a chat function if people want to add chat there, or of course, if people want to raise their hand and try and join in directly, that would also be great. I might find it difficult to see raised hands. So if I don't spot you, put a note in the comments saying, I've got a question. But we can kick off straight away with Mohammed Karoof, is it? So please, your question, Mohammed.
Hi, I'm Mohammed Crew from Tunisia. Thank you so much for the talks. My question is for Dr. Su. Thank you so much for this data. And I would like to ask, do you think, or do we have data about the impact of the removal of ovarian tissue for ovarian tissue cryopreservation on the AMH recovery and the future ovarian reserve? Thank you.
Yeah, so that's a good question, and I'll take a first stab and then perhaps anybody else who wants to join in. So we know in the general population that unilateral oophorectomy on average gets you age at menopause 1.3 years earlier, right? That's pretty well established. We know from some small cohorts where OTC, ovarian tissue cryopreservation, either by removing a part of an ovary or the whole ovary was removed, where the AMH levels, I think 1 to 2 years out, look very similar to people who didn't have the ovary tissue removed. So I think that because when it's removed when you're so young and the underlying reserve is so large, I don't think that there's a big impact on AMH unless someone else has data or wants to speak to data that I'm not aware of.
Thank you.
Thanks very much indeed. We have another question from Judy Sims.
Sandan, it's okay. Thank you very much. I'm from the University of Miami and have the great pleasure of working with Pasquale now. But my question, and I can ask him many things anytime, but Dr. Su, this one is for you. It'd be great if our patients had every 6 month or even annual AMH levels done after chemotherapy or bone marrow transplant or stem cell transplant. I'm an adolescent gynecologist. Oftentimes my patients are very much lost to follow-up and come to see me after 10 years status post-transplant with an AMH level the first time I'm drawing of 1.5 or below. And I'm concerned about following some of these patients prospectively, looking for an even lower AMH level, and was curious. My inclination is to refer immediately to options for oocyte cryopreservation at this point in time. Didn't know your guidance on following patients who are lost to follow-up and come to see you after a great amount of time, and do you have an AMH that you look for that says this patient needs treatment sooner rather than later?
So I think that's such a great question. And as you know, even in the general population, AMH is only good at predicting time to menopause if you're like in the last year prior to amenorrhea off of the SWAN studies. And we don't have that for cancer survivors. There's a lack of data. And I think, though, that I'm drawing off of, this is clinical advice, not data-driven, but I'm drawing off of AMH as a measure of how many eggs you're going to retrieve. That's one piece of data. And then the second piece of data, assuming that because you're an adolescent gynecologist, that means that most of your patients are childhood cancer survivors. Right. And there's really nice POI data off of St. Jude's lifetime cohort and CCSS. So if you have somebody who has a reasonable AMH for stimulation, and if you know off of CCSS and St. Jude's life data that their risk of POI is at least moderate, then this becomes a shared decision making that the yield would be good, and it's time to go for it. Mm-hmm. And then at the end of all of that, though, even if you have decreased ovarian reserve and you know that this person is at least 2 to 3 years out, this is probably the best you're going to get, and you know that they are at risk of POI, then I think that's on the side of probably trying to go get oocytes in those patients.
Thank you. That's been my impression. I appreciate it.
I think this is a really important question, because I think what you've said is to some extent what you would anticipate on the basis of thinking about AMH declining, but actually your own data show this very long plateau, even when it's been reduced by moderate gonadotoxic therapy. And actually, I think we need a bit of a pause and a rethink that our assumptions about rates of decline, I think it's all a bit up for grabs, actually, that if it's a reasonable AMH, it may stay a reasonable AMH for the next 20, 30 years. And causing that patient to spend, $10,000 on something that actually might be completely unnecessary. Great for the doctors who are taking their cut, but not in the patient's interests.
So I totally agree with that. And I think that maybe the sort of second point is to look at the clinical outcome data, right? Because AMH is a surrogate. And so your clinical outcome data are going to be the POI data from CCSS and St. Jude's. And that's clear what those risks are. So you're right, your AMH at 1 could stay at 1 for a long time, but you also know what that person, based on her treatment, what her POI rate is. And if that's not an inconsequential rate for that patient, then that might drive you, even though that AMH level may be stable.
But if she's 5 years out of treatment, she's one of the ones who hasn't got POI.
Oh, well, but POI is anytime before 40, right? So you have a 14, 15-year-old.
Well, I'm not sure that the St. Jude's data really yet terribly robust on that. You know, most of it's on very short-term, fairly immediate ovarian failure rather than, you know, amortizing it over the next umpteen decades.
I guess I'm thinking about like the two sets. One is the acute ovarian failure calculator. So that's like you're done within 5 years. That's the calculator they've got on the website. But the second is the original CCSS data to look at by age 40. So
long term,
the longer term data.
Yeah. But I think, you know, again, that was, you know, without building in the complexity of the data that you were demonstrating of, you know, if your ovaries have survived, they may continue.
I think that's really compelling because there's less panic. Sorry.
Yeah, I totally agree. I think that's the flip side, right? Is that I think we went from, you know, perhaps still the general sort of sense that you have chemotherapy and you're going to have some risk, but actually many treatments don't incur risk. So I think
if I may also make a comment on this, which is an extremely important point that Judy and Irene and Richard we are discussing, is that a couple of things we really don't know. We really don't know how plastic and dynamic is the adjustment that the primordial follicle pool can make as a maybe a partial number of primordial follicles, they've been really irreversibly damaged, and therefore there is going to be a decreased output, but it's never going to become zero, as Richard was assuming, because after 3 or 4 or 5 years, and you still have an AMH which is low, but you are still having cycles, even though they are sporadic. Well, you're still having cycles. The question is, I think we should really know, do a better job in having AMH values at the baseline before the patient starts any chemo or any type of treatment. We should have it at least a couple of AMH and see exactly from, you know, what was the background, what is the baseline. We do have patients that have low AMH to start with, but that doesn't mean that they are in the POI. They just have fewer follicles in the cohort. As opposed to others that have larger numbers. And I also want to stress that to me it's very important to know the genetic background in terms of cancer mutations, because if it's true that there is an impact on ovarian aging and decreased longevity from this type of mutations, I think that they should be incorporated in any algorithm that we are going to be using to predict or to study or talk to the patients, including also the fragile X mutations, by the way.
I think that was also something I was thinking very much as I was listening to your talk, Irene, as well, of the impact of pre-treatment AMH and being able to, you know, as you just indicated, Pascali, you know, if an AMH is low afterwards, you don't know how much that has fallen if you don't know what it was beforehand. The other interesting aspect, I think, that is really intriguing to me is this interaction with age and how that will change with age, and whether the older ovary has a different capacity for repair, for recovery than a younger ovary, independent of the number of follicles within it, you know, perhaps reflecting the degree of fibrosis that's in the ovary. So I think these are other really interesting things that inform your data, Irene, as well, and really a stimulus for further work. We got a hand up from Melanie Davis. Melanie, nice to see you. Please go ahead and ask your question.
Hi, Richard. I'm so sorry to commit the cardinal sin of arriving so late, but I couldn't help butting in and agreeing with what you were saying about post-chemotherapy freezing. I had a discussion with a group from France yesterday on this topic, and I wondered if there was anyone from France in the audience today, because they were telling me that there is funding for patients to have post-chemotherapy fertility preservation if they didn't have the opportunity beforehand. And I was arguing vociferously that I couldn't see any point in that because the damage was done. And this is a bit of an extension into what you were saying. If somebody could show me that post-treatment fertility preservation yields better pregnancy rates than natural conception, okay, that would win over my opinion. But at the moment, I'm seeing young people with unrecordable AMH and occasional cycles go on year after year after year into decade and more without becoming POI, and quite a lot of them get pregnant because they're young and they're having some cycles.
The long-term but low plateau.
Yeah.
Yeah. Irene, would you like to comment on that?
Yeah, I guess sort of two thoughts for that. I totally agree, and I think that's the cornerstone counseling is that this fertility preservation does not obviate trying on your own, because for as long as you have eggs, prognosis is good. So I was thinking, as Dr. Patrizio was talking about the PRP case, how often pregnancy happens in people who are deemed POI anyway. So it just might be also sometimes chance, right, that you developed a follicle that month. But to the second point is, if you had $1 billion, and in the States we do a lot of sort of shared decision making, if you had $1 billion that you can spend freely, and because we lack data on exactly when menopause or the end of the fertility window happens for these young cancer survivors, and if you know that mechanistically or by other sort of surrogate measures that some treatment has decreased their reserve, then overall, what is the harm of undergoing freezing eggs so that you have a backup plan should the first plan not work?
So Melanie, if money is no object, would you just go ahead and freeze them anyway? And you could, of course, extend to every woman on the planet who's post-pubertal, she should freeze her eggs just in case.
I mean, I am in California where there's a lot of, tech coverage of this kind of situation, not advocating for it, but in this case where there has been some risk, I'm curious. I know it's really controversial.
Yeah. No, that's a really good point. And I'm in central London where women are freezing eggs, every day. But I think there are potential harms. I think that the anxiety created through telling somebody that she is infertile just because she's got a lower AMH is huge. And I think the process of going through egg freezing is actually quite challenging.
Yeah.
And okay, there's a small physical risk, not a very great one, but it is a surgical procedure. So you can really only undertake it if you know it's going to benefit the patient. Well, that's my ethical stance anyway. If a woman will come and say, I want this and I'm prepared to pay for it, will you do it to everybody, for everybody? Or will you say, actually, there is no point when you're in a relationship and you're having some cycles? Just go on and try to conceive.
And in relation to that, Irene, I was struck by you had chosen a patient for your proposed patient who was only 14 years old. And maybe that is a situation where the concerns that Melanie just raised are perhaps amplified compared to a 30-year-old.
Yeah, I chose that patient, because I saw her not so long ago and had to go through this decision making with her. I guess a couple of reflections. One is really around that decreased ovarian reserve does not mean that you're infertile, and that should be a key part of our conversation, right? So if we go through fertility preservation, you get 5 eggs, this does not mean that you're infertile. And I often cite Ann Steiner's JAMA paper as a demonstration of that. And then for that 14-year-old, it's really to stir up conversation among us about sort of the ethics, about shared decision-making with adolescents and their parents. But yeah.
Yeah.
Right. We have another hand up from Brooke Chervin. Brooke, would you like to ask your question?
Yes. Hi, thank you. I'm Brooke Chervin. I'm a nurse scientist at Emory University, and I actually am doing some research into psychological factors and other factors that influence decision-making for emerging adult female survivors to potentially pursue fertility assessment or potential fertility preservation. So this is such a timely talk and discussion. I'm so excited. I was just wondering, Dr. Su, in your experience, when you are doing this shared decision-making with patients, what kind of factors do you find influence their decisions the most to either go forward with fertility preservation or not? Do you think it's driven a lot by age or their internal values of potential biological parenthood, cost? What have you seen in your clinical practice?
Yeah, I think all of those things here in California, where our state level mandate sucks. The mandate for fertility preservation actually is not being implemented well at all. Cost drives this decision, unfortunately. But for the adolescents that we see, it's so variable how many kids come in and they know this is what they want. As a mother of teenagers, my kids don't know that. But the ones that it's a selection bias of who actually gets into the door of an REI.
And Brooke, I also would like to add to your very good question, and congratulations for your studying this topic, is that also the concept of once you explain the various options, there are reactions beside the cost, of course, that are probably top. Also this concept of genetic relatedness. So, which I still cannot put my head completely around it, in that, there are some patients, they are so focused on having, no matter what, even if the odds are not so much in their favor, of trying, of doing, because of the genetic relatedness to have an opportunity to reproduce. Because there are other options, obviously. Someone was saying before when I was talking, there was the journey, say, oh, there are egg donation. Sure, there is egg donation, but that's not an immediate solution, or adoption is not an immediate solution. But before I finish my comment, I also want to bring up the issue that Dr. Gwendolyn Gwynn has brought up in the chat, in that we should also don't forget that is not only POI important for reproduction and issues of reproduction, but also the POI that brings other comorbidities. And, there is bone health, cardiovascular risk that need to be addressed. And so it's not only POI for fertility concern. Is that what Dr. Quinn was alluding to? So we should really be careful ordering a DEXA scan, weight-bearing exercise, vitamin D, calcium, lifestyle modification, blood pressure control, and even consider HRT if that's the case.
And on top of that, of course, Pascali, we have consideration of fitness for pregnancy for some of these patients if they've had high doses of anthracyclines, cardiac radiotherapy, all these sorts of other issues also come into play as well to inform the conversation.
Now that's why it's not really it's not a 15-20 minutes consultation. I always try to book at least 45 minutes to an hour for this type of a consult, and it's very important. We spend time, we look at the entire pictures and ask for as much as information possible when we see them.
So I'm afraid that actually our time is up for this, and I think what we've demonstrated in the discussion we've had this evening of quite what a challenging and complex area this is. Clearly, there's a need for a lot more research. There's a need for huge amounts of discussion with our patients about the uncertainties and the options that they have. This has been greatly informed by our two fantastic speakers this evening who've given us such a lot to think about. And thank you all for your contributions to the discussion as well. It's really great, a bit of audience participation from a range of different perspectives and indeed different continents. Europe, Africa, North America, all been represented on the discussion today, which is just brilliant. This is what the Oncofertility Consortium is all about. So particular thanks to our speakers, Irene, Sue, Pasquale, Patricio, for giving us such a lot to think about tonight. And thanks to the Oncofertility Consortium for their organization behind this. And thanks to everyone for joining and contributing. And
thank you.
Love to see you all. Till next time.
Thank you.
Thank you all.
Okay, good night, everybody.